Section 6 is on adult reconstruction. Hip disorders. Osteonecrosis or avascular necrosis of the hip commonly occurs between 20 to 50 years of age. 50% are bilateral. Commonest etiology is idiopathic, and next commonest is corticosteroid use. Staging of avascular necrosis of the hip. FECAT and Arlett staging uses radiographic views. FECAT has described 4 stages. ARCO, which is Associated Research Circulation Osseous, has standardized FECAT stage classification with the addition of MR imaging. ARCO staging system is Stage O, which is histologically positive. Stage 1, normal radiograph but MRI is positive. Stage 2, sclerosis on the X-ray but no subchondral collapse. Stage 3, subchondral collapse. Stage 4, degenerative changes or arthritis. Each of these stages are subclassified into A, B and C. Treatment. Stage 1 and 2, core decompression. Stage 3 and 4, osteotomy, salvage procedures or arthroplasty. Osteotomies around the hip can be either reconstructive or salvage procedures. Assessment is mainly clinical, radiographic or 3-dimensional CT scan assessment. Few points on intertrochanteric osteotomies of the femur. Sore sill is horizontal subchondral density and is a feature of normal physiologic loading. Gothic arch is the remodeled bone supporting the acetabular roof with the sourcil at the base. Increased sclerosis at the edge of the acetabulum suggests lateral overload, and if it is present, look for large lateral osteophyte. Look for large medial osteophyte on the femoral head, otherwise called capital drop, which may be an indication for valgus osteotomy. Preoperative evaluation, patient selection, acceptable passive range of motion are essential for the successful proximal femoral osteotomies. Cumulative necrotic sector angle less than 200 degrees in avascular necrosis has shown favorable outcome after proximal femoral osteotomy. About pelvic osteotomies, these can be reconstructive pelvic osteotomies or salvage procedures. Radiographic evaluation for acetabular index is abnormal if it is more than 30 degrees. Center edge angle of Weber is normally less than 20 degrees. Some of the periacetabular osteotomies for hip dysplasias are Gans osteotomies, Tony's osteotomies or Dega osteotomies. Chiari is a salvage procedure. Hip arthroplasty. Preoperative evaluation for anesthetic assessment and radiological evaluation for operative planning are essential for hip arthroplasties. Special considerations and problems should be anticipated in the following situations. In a patient with renal transplantation, avoid inadvertent compression of the renal transplant during positioning of the patient. In diabetes mellitus, 6.5% infection rate with high myocardial infarction has been reported. Gaucher's disease has high rate of loosening. Cerebral palsy has high rate of dislocations. Hematological problems like sickle cell disease, thalassemia and hemophilia will need special considerations for bleeding problems. Psoriasis has deep infection rate of 5.5% or around. Lupus erythematosus and AVN due to steroids have high rate of deep infection. Juvenile rheumatoid arthritis has extremely high rate of loosening. Femoral neck fractures have shown exceedingly high failure rates after total hip arthroplasty as a primary procedure. Results of secondary replacement were found to be as good as those of primary total hip replacement following displaced femoral neck fractures. Developmental hip dysplasias are faced with technical difficulties and high rates of failures. Surgical techniques of hip arthroplasty must include preoperative planning and prosthetic selection. We need to be familiar with the following aspects of hip arthroplasty. Number 1, antibiotic prophylaxis. Number 2, DVT prophylaxis. Number 3, surgical approaches. Number 4, acetabular preparation and version. Number 5, femoral preparation and version. Number 6, cement techniques. And number 7, post-operative care. Complications of hip arthroplasty are: 1, intraoperative complications. 2, heterotopic ossification. Significant risk of heterotopic ossification is present in patients who have had previous heterotopic ossification, male sex, heterotopic osteoarthritis, active ankylosing spondylitis, and in patients who are of advanced age. Posterior approach have lower rate of heterotopic ossification. Bruker's classification of heterotopic ossification is: Class 1, isolated islands of bone seen on the X-rays. Class 2, gap between the bones at least 1 centimeter. Class 3, gap between the bones less than 1 centimeter. And Class 4 is apparent ankylosis. Third complication, a third aspect we need to know, is DVT prophylaxis. 4, instability or dislocations after hip replacements. 5, neurovascular injuries. 6, femoral fractures. 7, loosening. Growth zones of femoral stem are 1 to 7. 1 is on the greater trochanter as 7 is on the calcar. DILI has 3 zones of acetabulum for detecting or for recording the loosening of the acetabular component. Acetabular deficiencies in total hip arthroplasty is classified as follows. Type 1, segmental deficiencies. A peripheral segmental deficiency can be superior, anterior, or posterior. B, central segmental deficiency with absent medial wall. Type 2, cavitary deficiency. A peripheral cavitary deficiency can be superior, anterior, or posterior. B, central cavitary deficiency with intact medial wall. Type 3, combined segmental and cavitary deficiency. Type 4, pelvic discontinuity. Type 5, arthrodesis. Classification of femoral deficiencies are as follows. Type 1, segmental deficiency. A, proximal can be partial or complete. B, intercalary, or C, greater trochanteric segmental deficiency. Type 2, cavitary deficiency can be cancellous, cortical, or ectasia. Type 3, combined segmental and cavitary deficiency. Type 4, malalignment can be rotational or angular. Type 5, femoral stenosis. Type 6, femoral discontinuity. The knee. Meniscal injury. Superior and inferior branches of lateral and medial geniculate arteries is the vascular supply to the meniscus. 20 to 30% of the periphery of each meniscus is vascular. The rest of the meniscus gets nourishment from the synovial fluid. Some key points in diagnosis of meniscal injury are: 1, history of twisting injury to the knee. 2, late, often overnight appearance of knee fusion. 3, history of knee locking. 4, positive McMurray's and Apley's test may be present. MRI grading system of meniscal lesion is described by Stoller as grade 1, intra-substance meniscal tear, tear not communicating with the joint surface or the capsule. Grade 2, linear intra-substance tear involving the capsular periphery but not the joint. Grade 3 is when the tear is communicating with the articular surface of the meniscus, or a true complete tear. Factors determining the treatment of meniscus are: age of the patient, chronicity of the tear, daily activities of the patient, location and length of tear, and associated ligament injuries. Types of the tear can be degenerate tear, horizontal tear, radial tear, oblique flap or parrot beak tear, vertical longitudinal or bucket handle tear, and complex tear. Techniques of meniscal repair and reconstructions are open repair, all inside arthroscopic repair, outside in arthroscopic repair, inside out arthroscopic repair, and meniscal transplant. Anterior cruciate ligament injury. ACL encounters 400 to 500 Newton force during walking. This force can increase up to 1700 Newtons during sporting activities. Load to failure of ACL is 2500 Newtons. ACL is predominantly made up of type 1 collagen. Counterforce from hamstring during quadriceps exercises reduces anterior tibial translation in anterior cruciate ligament deficient as well as anterior cruciate ligament reconstructed knees during extension. This is the principle behind closed chain kinetic exercises. Goals of treatment of ACL reconstruction are increase stability and improve the level of function, as well as to prevent progression of osteoarthritis, which is still hypothetical. Diagnosis of ACL tear is mainly clinical, positive Lachman test with absence of firm endpoint, X-rays to rule out any bony pathology. MRI is often a useful diagnostic tool. Treatment options are rehabilitation exercises or surgical reconstruction. Surgical reconstructions can be 1. Primary repair, 2. Primary repair with augmentation using synthetic materials, 3. Late reconstructions using autografts, which is the most popular modality, 4. Late reconstruction using allografts like cadaveric Achilles tendon, 5. Late reconstruction using prosthetic synthetic materials, and 6. Extra-articular reconstructions like Macintosh augmentation. Most commonly used technique is bone patella tendon bone autograft. Regimes of post-op rehabilitation is controversial. Most believe in full range motion exercises as soon as possible. Combined injuries. O'Donoghue has described a triad of ACL rupture, medial collateral ligament and medial meniscal injury. Principles of treatment of combined injuries. Number 1. Isolated medial collateral ligament injury is treated non-operatively, whereas number 2, anterior cruciate ligament with meniscal injury is treated by early repair of meniscus and ACL reconstruction. Number 3, anterior cruciate ligament with medial collateral ligament injury, timing of treatment is controversial. Most believe that medial collateral ligament repair along with ACL reconstruction is most beneficial. Injuries to posterior cruciate ligament. Humphreys ligament is meniscofemoral band anterior to PCL, and Risberg ligament is the meniscofemoral band posterior to PCL. Mechanism of PCL injury can be, number 1, hyperflexion with or without anterior tibial force as in dashboard injury. Number 2, hyperflexion with downward force on the thigh. Or number 3, hyperextension with or without varus valgus force, which is the common cause of PCL injury in association with other intra-articular pathology. Diagnosis of PCL injury. Number 1, history of typical mechanism of injury. Number 2, clinical examination might show positive posterior drawer sign, positive posterior tibial sag sign, positive quadriceps active test, positive posterolateral drawer test with foot externally rotated to 15 degrees is suggestive of associated posterolateral instability, positive posteromedial drawer test with foot internally rotated to 15 degrees, positive external rotation recurvatum test or positive reversed pivot shift. Number 3. X-ray and MRI scans are useful diagnostic investigations. Goals of treatment of PCL injured knees are: 1. Achieve stability of the joint. 2. To restore kinematics. 3. To prevent progression of osteoarthritis. Treatment of isolated PCL injury reconstruction in an asymptomatic person is still controversial. Options available are: open procedures or arthroscopic assisted procedures. Grafts may be synthetic or fresh frozen Achilles tendon allografts. Posterolateral rotary instability of the knee. Anatomically, posterolateral complex consists of lateral collateral ligament, popliteofibular ligament, popliteus tendon, patellofemoral ligament, arcuate ligament, short lateral ligament, and posterolateral joint capsule. Transection of posterior cruciate ligament, lateral collateral ligament, and posterolateral complex results in the greatest amount of posterior tibial translation at all angles of knee flexion. Isolated PCL does not affect external tibial rotation. Transection of posterolateral complex alone results in increased external rotation of tibia at 90 degrees of knee flexion. Transection of lateral collateral ligament and posterolateral complex results in increased tibial rotation in all angles, maximum at 30 degrees of knee flexion. Patellofemoral disorders. Patellofemoral malalignment can be due to: 1. Bony abnormalities, 2. Soft tissue and muscle imbalance, and 3. Patellar abnormalities. Patellofemoral joint's reactive force is approximately half the body weight during normal walking and greater than 3 times when climbing the stairs. Lateral facet is first to make contact with the femoral condyles. Diagnosis of patellofemoral disorders: number 1, pain and instability. Number 2, clinical examination in patella malalignment are as follows. Normal Q angle is about 15 degrees in men and 15 to 20 degrees in women. J sign is patella tracking laterally during the terminal phase of extension. Patella tilt test. Normally, patella can be passively tilted 0 to 20 degrees. Lateral tilt less than 20 degrees indicates lateral tightness. Medial and lateral patella glide test. Normal glide is 1 to 2.5 quadrants at 30 degrees of knee flexion. If it is greater than 3, it is abnormal. Patella may be abnormally tight or abnormally lax. Fairbank apprehension test may be positive in recurrent dislocations of patella. Number 3, X-ray examination of patella malalignment consists of Merchant's view, which is taken with knee flexed to 45 degrees and X-ray beam angled 30 degrees from the horizontal. On these X-ray views, normal sulcus angle is 140 degrees plus minus 5 degrees. Normal congruence angle is minus 6 degrees plus minus 11 degrees. Lateral patellofemoral angle normally is open laterally. Look for patella alta or patella baja on lateral views. If distal pole of patella lies above the Blumensaat's line, it is generally an alta patella. Normal insoles ratio index is 1.2. Outer bridge classification of articular cartilage degeneration is: Grade 1, softening and swelling of the cartilage. Grade 2, fissuring and fragmentation, area less than 1.3 centimeters. Grade 3, fissuring and fibrillation, greater than 1.2 centimeter area. And Grade 5, extensive erosion down to bone. Treatment options: rehabilitation via more exercises or operative treatment. Operative treatment consists of either of these or any of these. Number 1, lateral retinacular release, which can be arthroscopic or open technique. Number 2, combination of lateral release and medial capsular reefing. Number 3, medial realignment procedures like Emsley-Trillard procedure, where tibial tuberosity hinged medially over the periosteum. House's procedure, where tibial tuberosity is transferred medially. Galeazzi's technique is semitendinosus tenodesis to patella. Rowe-Goldwaite procedure is split medial transfer of patellar tendon. Number 4, anterior realignment procedures like Mackay technique. Number 5, anteromedial realignment of the tibial tubercle. Degenerative diseases of the knee joint. In considering osteotomies for unicompartmental knee disorders, upper tibial osteotomies for genu varus and distal femoral osteotomies for genu varum are to be preferred. Complications of upper tibial osteotomies are: 1. Inadequate valgus correction. 2. Overcorrection. 3. Too close to the joint and intra-articular injuries. 3. Avascular necrosis. 4. Popliteal artery injury. 6. Compartment syndrome. 7. Peroneal nerve palsy. 8. Delayed union or non-union of the osteotomies. Medial compartment osteoarthritis do better than lateral compartment osteoarthritis with unicompartmental joint replacements. Indications for unicompartmental knee arthroplasty: 1. Age of the patient less than 60 years. 2. Heavy or physically active person. 3. Unicompartmental disease. 4. Prerequisite of less than 10 degrees of fixed flexion deformity and more than 90 degrees of flexion should be respected. Total knee arthroplasty approaches: anterior approach, southern subvastus approach, and lateral approach. Technique of arthroplasties involve pre-op planning, infection and DVT prophylaxis, skin care, limb alignment, implant sizing, ligament balance, flexion extension gap, and post-op rehabilitation. Complications of knee arthroplasty are: 1. Infection. 2. Loosening and revision surgery. 3. Periprosthetic fractures. 4. Patellar and extensor mechanism problems. Foot and ankle. Anterior to ankle are remembered with the mnemonic tibialis anterior, artery, extensor hallucis, artery, nerve, extensor digitorum, and peroneus tertius. Structures on the medial side of the ankle are remembered with the mnemonic tall doctors are never happy. Tibialis posterior, flexor digitorum, artery, nerve, flexor hallucis. Common ankle approaches are anterior, anterolateral, and lateral gatelier approach. Commonly used subtalar joint approaches are Cocker's approach or Ollier's approach. Names of some of the ankle arthrodesis techniques are RAF technique, Chanley's compression arthrodesis, Blair's sliding graft technique, Colandriccio triangular compression technique. Some of the names of subtalar arthrodesis techniques are Norton-Dunn technique, Denison-Fulford technique, and Lambrinudis technique. Hallux valgus is a combination of following abnormalities of big toe. Number 1, bunion. Number 2, lateral deviation of proximal phalanx. Number 3, metatarsus primus varus. Number 4, subluxation of sesamoids. Number 5, pronation of great toe. First, MTP joint has static and dynamic stabilizers. Static stabilizers are capsule, collateral ligaments, and sesamoid ligaments. Dynamic stabilizers are abductor hallucis, medial slip of flexor hallucis brevis, and two heads of adductor hallucis. Normal hallux valgus angle is up to 15 degrees and intermetatarsal angle is 9 degrees. Some of the options of hallux valgus surgeries are silver bunionectomy, McBride soft tissue release, chevron osteotomy, Mitchell osteotomy, basal osteotomy, arthrodesis of first MTP joint, Lepidus procedure, Keller's procedure, and Akin's proximal phalanx wedge osteotomy. Lesser toe deformities are: 1. In mallet toe, flexion deformity is at the DIP joint. Treatment is by removal of distal condyles of middle phalanx. Number 2. In hammer toe, flexion deformity is at proximal interphalangeal joint. Fixed deformity is treated with Dury's arthroplasty, and if the deformity is flexible, girdle stone flexor tendon transfer is considered. Number 3. Claw toe is hyperextension deformity of the MTP joint associated with any type of deformity at DIP and PIP joints. Hyperkeratotic disorders of lesser toes are either hard cone, which has callosity over the dorsolateral aspect of little toe, or soft cone, where the callosity is in between the toes. Bunionette or Taylor's bunion can be due to large lateral condyle of fifth metatarsal or due to laterally deviated fifth metatarsal. Normal intermetatarsal angle between fourth and fifth toes is 6 degrees. Plantar callus is often associated. Intractable plantar keratosis can be discrete or diffuse intractable plantar keratosis. Treatment is orthotic.